Good afternoon, doctors. Thank you for joining us today. I welcome you to this webinar organized by Neuroendoscopic Society monthly webinar. This is series 2. Today's topic is posterior fossa arachnoid cysts, endoscopic techniques, and suprasellar arachnoid cysts, strategies and pitfalls. This is coming to you through a digital initiative known as DigiNeuro from HealthNU, a joint venture with Llewellyn Company Limited, Japan. HealthNU has a mission to fulfill unmet medical needs, and we launch innovative first time in India products. For example, Amnurite, Amitriptyline plus Bicobalamine. For the first time in India, we launched about 6-7 years back. Amnurite 5, Amnurite 10 and 25. 5 being a new strength in Amitriptyline, which was always wanted by neurologists and neurosurgeons for neuropathic pain and for migraine. We have Amnurite beta when migraine is not controlled by one drug, Amitriptyline and propranolol combination, Amnurite beta 520ER and Amnurite beta 1040ER. The first pharmacological combination for neuropathic pain of two neuroanalgesic Amnurite P, where pregabalin is given in a sustained release form to match pharmacokinetic profile of Amitriptyline to give your patient 24 hours pain relief. Amnurite P. It is pharmacological. We have Bicobalamine injection imported from Japan to give you highest quality in neuropathic pain, Neurite. We have launched a strength that was required by pediatric neurologists and neurosurgeons, 2.5 milligram in clobazam. Add clobazam 2.5, 5 and 10 in mouth dissolving form, add flexibility, add control in your treatment of epilepsy. And recently we have launched a new concept, vitamin therapy in migraine, riboflavin 200, magnesium 200 and CoQ10. This is proposed by AN and International Headache Society. Brentamine, vitamin therapy for migraine. This webinar and all our earlier webinars are available on a DigiNeuro channel, which is there on YouTube. So today's webinar will be uploaded tomorrow on the DigiNeuro channel. This is turning out to be a good resource for neurosurgery. About 40 plus webinars are available and about 30 to 33 are from neurosurgery. So please do visit, like and subscribe to this channel so that next webinar you can get a notification. Now I have a great pleasure in today's introducing coordinators of today, and we have none other than Dr. Suresh Sankhla, consultant neurosurgeon, Global Hospital, Mumbai. He is the current president of Neuroendoscopic Society of India, as you know, has also been the past president of Indian Society of Pediatric Neurosurgery, past president of Indian Society of Neuro-Oncology, past president of Skull-Based Surgery Society of India, past president of Bombay Neurosciences Association. He is currently chairperson of Communication Committee of Asian Australasian Society of Pediatric Neurosurgery. Sir has been also founder editor of Journal of Pediatric Neurosciences, Mumbai. So, sir, welcome to this webinar, Dr. Suresh Sankhla, sir. Okay. We also have Dr. Ashish Pathak as our another coordinator. Sir is director of Neurosurgery, Fortis Hospital, Mohali, former professor of neurosurgery of prestigious PGI Chandigarh, former consultant pediatric of neurosurgery NHS UK Sheffield, and former lead of vascular lead respiratory and skull based neurosurgery NHS UK Kingston, past president of Cerebrovascular Society of India. Sir has also been honorary secretary of Neuroendoscopic Society of India and former honorary EC member of Indian Society of Pediatric Neurosurgery and Indian Society of Neuro-Oncology. So I have great pleasure and privilege to hand over the session to Professor Dr. Ashish Pathak to carry on this webinar. Thank you.
Thank you, Mr. Deepak, for the kind and generous introduction. First of all, it's a matter of pride and privilege for us to again conduct the second webinar series in neuroendoscopy on behalf of the Neuroendoscopic Society of India. And I must thank our president, Dr. Suresh Sankhla, who actually took the initiative, and both of us could manage to get into this series. Now, at the very onset, I invite all the members of the Neuroendoscopic Society of India who are already participating in this. And I also invite the other non-members, but who are neurosurgeons interested in this field, to join this webinar and, of course, contribute as well as update their knowledge in this field. Today's seminar, as you already heard, are on two very important topics based on cystic lesions in the brain. We have got two eminent speakers who will be formally introduced. But at the same time, we have got three eminent panelists, and to introduce them, we have Dr. Manas Panigrahi. Dr. Manas Panigrahi is a speaker. Dr. Venkatraman, who is founder, chairman, and chief neurosurgeon of Brain Hospital, and his chairman and managing director of ONNSA Research Innovation Private Limited. He is the present president of the Cerebrovascular Society of India, and he is executive manager and member of the International Federation of Neuroendoscopy. He is also a member of the WFNS Neuroendoscopy and Neuroendocrine Committee, and he is the past president of the Neuroendoscopic Society of India, and also the past president of Pediatric Neurosurgery and Indian Society of Stereotactic and Functional Neurosurgery. So he is a very renowned person in the field of endoscopy so far as India is concerned. The other panelist, of course, is no less than Professor Arivazhagan, who is Professor of Neurosurgery in the prestigious National Institute of Mental Health and Neurosciences, Bangalore. His deep interest in neuroendoscopy, which includes transcranial and skull-based procedures, are really very important. He is also interested in neuro-oncology, epilepsy surgery, functional neurosurgery, and he has been observer in epilepsy surgery in Toronto. Welcome, Dr. Arivazhagan, please. And last but not the least, very eminent and senior person, Dr. Hemant Bhartiya. He, after doing his post-graduation and then doing his MCH in neurosurgery from Mumbai, he established neurosurgery in Jaipur. He joined the SDM hospital in Jaipur in 1988, and he was the consultant and head of the department there. And then now he is, of course, the director and head of the department of neurosurgery at Fortis Hospital in Jaipur. He also has a long list of laurels to his credit. He had been fellow in New York University, Atkinson Mole Hospital, John Hopkins University, Baltimore, Pediatric Neurosurgery Clinic, Paris, Queen's Medical Center, Nottingham, and Fujita Health University, Japan. He has been the past president of the Neuroendoscopic Society of India. Dr. Bhartiya, of course, is one of the pioneers who established a lot of new procedures in Rajasthan specifically, and his surgical experience reaches up to 12,000 procedures till date, and he has been awarded with various prestigious awards, which includes prestigious Raja Pajavan Dev Award, Outstanding Young People's Award, and he has greatly contributed to development of neurosurgery in Rajasthan. So these great panelists here, I think we expect a very vibrant and interactive session today. With this, I hand over the proceedings to our president, Dr. Suresh Sankhla, please.
Thank you, Ashish, for this wonderful introduction of the webinar. Today's webinar is the second in the series. We had the last month webinar, which went very successfully, and thanks to all our good panelists and speakers who really made it a very successful event. Today's speakers are also well known in their own field, and I would like to introduce the first speaker, Llewellyn Padayachi. Llewellyn has been a good friend of ours for last several decades or even longer. Llewellyn has spent a lot of time in the University of Cape Town, South Africa, doing neurosurgery, and recently he has moved to the University of Pretoria in South Africa. He is head department of neurosurgery there, and also looking after pediatric neurosurgery, which is his main area of functioning. Llewellyn is also known, and he has contributed tremendously in the international neurosurgery in the field of intraoperative ultrasonography, neuromonitoring, minimally invasive surgery, and neuroendoscopy. And today we are going to hear him talking about the management of intracranial or the posterior fossa arachnoid cyst. So Llewellyn, please
Thank you very much, Suresh, for
share
that.
your screen and
share my screen?
to hear to you.
Okay, just two things. You can hear me, Suresh?
Yeah,
Okay, and you can see my screen, yeah?
absolutely. Yes, thanks.
Okay, great. So firstly, a huge thanks to the Neuroendoscopy Society of India, its president, Suresh Sankhla, Dr. Ashish Pathak, and all the involved senior members, the panelists. It's always a massive privilege for me to be involved in these webinars, particularly the Indian Society, which I feel very strongly affiliated to. So when Suresh sent me this topic of posterior fossa arachnoid cysts, I realized very quickly it's not the easiest topic to talk on because of all the regions of the brain or the skull that we insert the endoscope into. The posterior fossa is probably the most complex, and I would venture to say probably the area where we use the endoscope the least. So I've got to acknowledge my colleagues, like Suresh pointed out. I spent a lot of time at University of Cape Town. So Graham Fegan and Tony Figaji, particularly with this talk, we did a lot of this work together. So a lot of the endoscopy procedures in the posterior fossa I actually did while I was there. So the outline of this talk, now I will do my best, like Dr. Pathak asked me to keep to time. I gather I've got half an hour, so I'll try my best to stick to that. We'll go through some general aspects, just the anatomical classification, presentations, some case presentations, and then the management options, and why endoscopy is an option in this anatomical region, but not the only one. So the definition of arachnoid cysts, I think if you look at CANAVs, it's probably the most widely used. It's a congenital fluid-filled compartment within the CSF cisterns or the major cerebral fissures, bordered by an arachnoid membrane. The key features which we need to be aware of are the fact that they're always extra-axial. The fluid which fills the cyst is identical to CSF in terms of its imaging characteristics. And while the cyst may compress adjacent structures, it's not an infiltrative type of lesion, so it's adjacent to normal brain. And it's important to realize that the bone overlying it may be bone and often deformed. The anatomy, very briefly, the arachnoid is a thin, delicate membrane, middle meningeal membrane, usually made up of two flattened layers of cells. The cisterns where these cysts occur are expansions of the subarachnoid space and often occur at the base of the skull. So why are these lesions of interest? Because of the distribution in the posterior fossa, which is incredibly variable. I'm going to ask, I can pick up quite a bit of background noise. Might just ask the moderator to mute some people. It's quite distracting. So the distribution in the posterior fossa is quite variable. And the diagnosis may be incidental following imaging for antenatal events, depending on how sophisticated the underlying infrastructure is for antenatal imaging. Patients often present, or children anyway, present with macrocrania, epilepsy, developmental delay, or minor head injury. The natural history in this particular subset is often very unclear, which makes diagnosis a little bit difficult to clarify. So minor traumatic brain injury, and we've seen this a few times now, may be complicated by cyst rupture. So they were completely incidental and then offset by minor traumatic brain injury. The management is very variable, and I'll go through them. Endoscopy is always an appealing option. In this particular area, I would argue maybe not so appealing, but we'll hear what the discussion is like afterwards. And for those of you interested, Knut Vester is a Norwegian professor of medicine and neurosurgery, wrote this text on arachnoid cysts, which is always worth a read. Epidemiology, quickly, it's about 60 to 80% are diagnosed in early childhood. So the vast majority in children under the age of 2 years old. There's a male predominance. 1% of intracranial mass lesions is what they constitute. There are certain described sort of familial or hereditary conditions, and quite a description of associated conditions, but they're pretty rare. The pathology, again, very briefly, I didn't want to be exhaustive with this. The pathological area is similar to normal arachnoid, except that the arachnoid cells may be hyperplastic in this area. It's often a thick layer of collagen, and they have absence of trabecular processes. The membrane themselves, and this is important when you're doing the MRI scans, if you ask your radiologist for particular scans, you may be able to pick up these prominent veins, foci of capillaries, ependyma, cuboidal epithelium, and choroid plexus, obviously slightly less obvious in the scan, but you need to be aware of them. The pathophysiology, there have been a few described mechanisms. The osmotic gradient into the cyst is claimed to be a higher protein content. This has subsequently been disproved in a few anatomical and physiological studies, but again, has been included in the armamentarium. The ball valve mechanism, reportedly been seen during endoscopy and with delayed filling following cystoscopy, but again, these are quite questionable. The active fluid fill production of the cyst wall itself, so it's claimed that the neurosecretory ultrastructure of the cyst wall is contributory in some cases. And then probably the most widely accepted is the pulsation-driven movement with these cysts expanding because of the pulsatile movement of CSF. It's also important to remember that these cysts may spontaneously involute in a significant number of patients. So the topographical distribution, they could be supratentorial. We know all of those, and I'm not going to focus on that because the context of this talk is posterior fossa. So in that context, they could be related to the cerebellar hemisphere, midline vermis, the cisterna magna, cerebellopontine angle. It could be retroclival or intraventricular. The imaging, like I said, often picked up on antenatal ultrasound. I've had a few referrals recently that have been picked up on antenatal ultrasound, went on to get an antenatal MRI scan, and we were able to treat these kids quite early on in their neonatal period. The CT scan, I would argue, is just diagnostic. The fluid is usually isodense, but you almost always, I would say always, need an MRI scan. Particularly useful sequences are the FLAIR, the Fiesta or CISS, depending on whether you've got a sort of Philips or Siemens machine. But what it does help you do is visualize the membranes a lot better. And I would argue that this is fundamental in your surgical planning. Cine studies have been shown to be useful in some of them, but in this particular pathology, maybe less so than in the Chiari malformations, for instance, or post-third ventriculostomy, where you want to assess CSF flow. For historical importance, CT cystoscopy has been useful diagnostically in the past. Plain X-ray films have shown expansion and thinning of the skull, which were also diagnostic. So the differential diagnosis, perhaps in this particular pathology, is more relevant than in most other pathological conditions because of the wide range of mimicking conditions. So it could just be a normal variant, the dilated subarachnoid cisterns, the Dandy-Walker malformation. I'll show some examples of that. Acquired lesions like post-traumatic porencephaly, arachnoid diverticuli, tumors, particularly epidermoid cysts, and I'll show an example of that as well. And then the parasitic cyst, hydatid cyst. I think this has caught out quite a few people. I think it's important to differentiate that particularly, and I'll show a video of that in a bit now. And then supratentorially, arachnoid cysts in the quadrigeminal plate can often be quite difficult to diagnose anatomically. And then something we've seen a lot of, and a good radiologist can help you make this diagnosis, is herniation of the atrium of the lateral ventricle across the tentorium cerebelli. You can see in this case here. These, with adequate MRI scan imaging, we're often able to diagnose these, and the treatment differs fundamentally, so you've got to make that diagnosis. Okay, so posterior fossa arachnoid cysts, specifically about a quarter of all arachnoid cysts. The location, like I've shown, retrocerebellar in about 9%, cerebellopontine angle, retroclival, fourth ventricle. And I think the imaging needs to include, and I've got a particular interest in multiloculated hydrocephalus, it's got to be very clear supratentorially as well to make sure that this isn't a diagnosis involving the supra and infratentorial spaces. The retrocerebellar arachnoid cyst, the two main forms, the midline lateral or lateral-posterior. The presentation is fairly typical, though. It's mostly raised ICP, so vomiting, irritability, macrocrania, delay. Rarely, interestingly, do they present with cerebellar signs or suboccipital headache. And some patients may actually just present with a suboccipital bulge. The differential diagnosis here, Dandy-Walker malformation or variant, depending on which terminology you prefer, megacisternal, megacisternal magna, Blake's pouch, cerebellar hypoplasia, epidermoid cyst, and then pilocytic astrocytomas also need to be borne in mind. So the Dandy-Walker malformation, you've got to remember, the classic features are agenesis of the vermis, high-riding torcula. They can occur with or without hydrocephalus, and then again, your treatment hinges on whether you think there's aqueductal patency or not, so whether you treat the ventricle supratentorially or not, you've got to bear that in mind, and some of these patients can present asymptomatically. The isolated fourth ventricle needs to be included here. It's not always an arachnoid cyst within the fourth ventricle, but I think definitely occupies a strong space in this type of pathology, typically seen in patients who have a VP shunt in the lateral ventricle, but not always. The treatment modality here, the aqueductoplasty, and we've treated more and more of these patients now. And right at the beginning, we sort of opened the aqueduct endoscopically, didn't place a stent, but now we routinely supratentorially place an anchored stent. And these videos will show how we do that. So endoscopically, supratentorially, you'll see we found that the aqueduct occluded. But with the arachnoid cyst, it's a little different. Obviously, you try and fenestrate the cyst, but the principle is still the same. And it would be interesting to hear afterwards. But for these fourth ventricle cysts, we often approach them supratentorially. And I'll just play all of these. And at the same time, you can see the steps from 1 to 2, placing the stent under endoscopic guide. The last one here with the stent anchored. So we then anchored the stent supratentorially within a Maya reservoir. The Chiari malformations, one's got to mention them in this differential 2, 3, and 4. I think they're fairly distinct, but you often need to bear that in mind because of how dramatically the treatment differs. CP angle arachnoid cysts. The presentation here is fairly typical. They may mimic CP angle tumors in adults, decreased hearing, tinnitus, impaired corneal reflex, facial pain. Late on, there may be cerebellar signs or raised ICP. The differential diagnosis, again, includes some of those that I've mentioned earlier. This is the case of a little kid with a chronic renal failure, posterior urethral valves, attention deficit. A CT scan wasn't clearly, it was suggestive of a lesion, but the CT scan, the MRI scan clearly showed a CP angle arachnoid cyst, which we then fenestrated endoscopically. And again, I mentioned the epidermoid tumor. I think it's very important to keep this in your differential, and MRI scans can quite comfortably nowadays differentiate or distinguish these from posterior fossa arachnoid cysts, both with the anatomical pattern. You need to you look at the signal, particularly on flare, and DWI, particularly the B1000 sequence. Complex malformations, remember, like I said, we need to get complete brain imaging, so supra and infratentorially. Kids with frontonasal and encephalocele can often have complex hindbrain abnormalities, and this is again the case I showed of posterior fossa cyst or herniated atrium of the lateral ventricle. Hydatid cyst, always bear these in mind. Remember, I'm showing that to make the point that not all of these should be treated endoscopically. I'll just show this video quickly to make that point. These need to be removed intact and in toto, and you can't do that endoscopically, so these patients need a craniotomy. So the treatment options then, you've got to remember that conservative management in these patients is oftentimes a very real option. All they need is reassurance. If there's no further imaging, or if you plan, which is very rare, observation where one plans to image them further and watch if they progress clinically, and then decide whether you need to do anything for them or not. And I think the important differentiation here is whether patients with posterior fossa arachnoid cysts present with symptoms purely of raised ICP and hydrocephalus, which needs to be treated, as opposed to compression from the cyst itself, so cerebellar symptoms of brainstem compression. And your treatment needs to be gauged on that, both with the clinical symptoms and what the imaging features show. So if we decide to treat them, then the fenestration really is the main goal, and that can be done via craniotomy and microsurgically or endoscopically. Placement of a shunt in these particular cases is something that is done quite routinely, either cystoperitoneal or ventricular peritoneal shunts, like I said, depending on whether patients present mostly with raised ICP or hindbrain compression. So this is a nice little treatment algorithm It depends on whether patients are clinically stable or whether they're symptomatic from local mass effect or hydrocephalus, like I pointed out. And based on that, you can decide whether patients need a craniotomy, fenestration, endoscopic fenestration, or assisted peritoneal shunt. And that is very subjective. It would be difficult to come up with an absolute recommendation. I think from center to center, from expertise to expertise, this would differ quite a bit. The use of adjuncts like neuronavigation or intraoperative image guidance, like things like ultrasound, are useful, maybe a bit less useful in this context, but certainly need to be looked at. And then depending on whether patients are clinically stable or not, or whether the hydrocephalus has resolved or not, you might then still need to place a VP shunt. So one needs to bear that in mind. So if you decide that the patients need a craniotomy, it's important because a lot of these will be done prone. So positioning is crucial. It needs to be tailored to the anatomical location. And particularly in children, you've got to be very careful when positioning them prone. And I won't go into the detail of it, slightly beyond the scope of this talk, but one needs to take all those precautions into account. You've got to try to open in a way always. I think this is a general surgical principle we all need to remember, that open in a way that will help you close and at least facilitate a watertight closure. Preservation of the musculoligamentous attachments to C2 is always useful. So technical issues, just a few things. Whenever you attempt to fenestrate the wall, it needs to be with sharp dissection where it's safe, and try to minimize bleeding to minimize arachnoiditis. So this is a kid, the same case where we did a posterior fossa craniotomy and fenestrated it microsurgically. And there are cases where you need to do that. You see the post-op scan looks pretty good. And then endoscopic fenestration, I would argue in this particular context, maybe requires a little more in the way of general philosophical application. So you've got to individualize every decision. Does one really need to apply the endoscope? What would the benefits be apart from the sort of, the appeal of endoscopic assisted fenestration? It depends very much on experience of the surgeon. I would suggest that in this particular pathology complex, that more experienced surgeons do this, and if you don't have, ask for assistance by a more experienced surgeon. So you've got to ask yourself why this approach is being chosen. So endoscopy is more ideal if the lesion is deeper and brain needs to be traversed. One can argue that an endoscopic option is more appealing, and you can do a craniotomy with superficial fenestration where the lesions are more superficial, and if critical structures are involved where you need more direct control. So the endoscopic surgical options, wider than just posterior fossa arachnoid cysts, remain fairly constant. So endoscopically, we can fenestrate membranes if they need to be fenestrated, so septations as well. Foraminoplasty, not really so applicable in the posterior fossa arachnoid cysts. Third ventriculostomy, I think, depending on the patient's clinical presentation and the imaging is an option. Choroid plexus cauterization, less so in this particular case. I don't think that has too much of a relevance. Aqueductoplasty, I think always needs to be considered so at least a stent with the aqueductoplasty needs to be considered for these, these encysted fourth ventricles, and then where relevant, retrieval of catheters or insertion. So the role of image guidance, I think, has entrenched itself very firmly into neuroendoscopy. And I would argue that navigation should be used in almost all these cases, infra or supratentorially. And if available, and if the skill set is available, something we found incredibly useful is the use of real-time intraoperative imaging, in our case, the ultrasound. I'll show this picture just quickly to show how useful it is to realize whether you fenestrated, a cyst or not. This is a cyst that's herniated up into the supratentorial compartment, but it's quite nice to know whether one's actually fenestrated them appropriately or not. So this is the case that I found described of a 7-year-old boy with progressive hearing loss and facial nerve weakness, was treated endoscopically, ETV and an endoscopic fenestration, and then needed to get a ventricular cystocystonostomy. So one may need more than a single approach in these. It's often, it's important to remember that. And there isn't sort of an absolute single technique or single method you can use to treat all these patients. So you've got to individualize the treatment modality based on how patients present. So I'm going to show this video. It's a patient who had a retroclival cyst, and we had to go sort of, transventricular, do a third ventriculostomy, and then fenestrate, at least open the membranes, case I did with a colleague of mine, Martin Schumann. See, so Martin Schumann and Hans Ludwig often advocate using the laser for third ventriculostomies. I'm not a huge fan of that, but in this case, we used the laser because we didn't want to change too many instruments. So this was a opening of the floor, and you'll see as you go through, the main goal to show here is the fenestration of you can see the membrane there within the retroclival space. So that was nicely fenestrated, and you can see we use the laser here. But again, that's quite nice if you can, but not an absolute must. Okay, so I think it looks quite clear that that's been open. Right. So shunts, and I think one's got to go through the full spectrum of treatment options for this condition. So microsurgical fenestration is one, endoscopic fenestration, but some patients, no matter how one tries to avoid that, will need a shunt of some sort, either cystoperitoneal or ventriculoperitoneal. And in a lot of these cases, it is the most straightforward treatment option. And you can see quite dramatic reconstitution of the cerebellum. But there are certain technical issues. So if hydrocephalus occurs, does one then shunt the ventricles, or do you consider shunting the cyst first? That's an incredibly important thing, because you've got to think carefully about the placement of the catheter in the posterior fossa. Oftentimes, if the catheter is, the trajectory is wrong, or it's placed in a way that when the cyst decompresses, the catheter can actually harm vital structures in the posterior fossa. And if a VP shunt is also required, our thinking has always been to avoid the Y connector completely. It'll be interesting to see what other people's thoughts are. So in summary, for posterior fossa arachnoid cysts, they're mostly retrocerebellar, so they're quite easily accessible. The superficial ones, like I said, probably more amenable to microsurgical fenestration. The deeper ones, consider using the endoscope. The cerebellopontine angle ones, cysts I found are more amenable to endoscopic fenestration. It's often an incidental diagnosis, so a lot of these patients don't really need to be treated. You need to put your treatment options or plan to treat in context of the patient's particular presentation. And again, I'll say it depends on whether they presented with raised ICP and hydrocephalus or compression of the posterior fossa structures. So again, these treatment options, like I said, include observation, fenestration, either microsurgically or endoscopically, and then you always need to consider whether these patients actually need a shunt or not. So this quote probably is about as applicable to this condition as it is to any others. I did then what I knew how to do, and now that I know better, I do better. So I think as one's skill set improves, we've got to modify, what we can do. And if you become more comfortable sort of endoscopically fenestrating with the adjuncts that are available, they're quite nice to use. But one thing I always say is we need to learn to use what we have at our disposal as best as we can. So thank you very much, and I'll hand back over to the moderators.
Thank you, Llewellyn. Thank you for this wonderful presentation. I think you really summarized the posterior fossa arachnoid cyst, which is such a complicated subject anyway, so nicely and so elegantly. I think before we take the questions and from the panelists, I would like to ask a question to you, Llewellyn. Whenever you decide to do the endoscopic fenestration in the posterior fossa, do you prefer straight, rigid endoscope, or you would prefer the flexible one, and why?
Suresh, that's a good question. I must say, particularly, so my workhorse endoscope is the OI Handy Pro. I've just become so comfortable with it. We do use the Minop as well, but the diameter is wider. So I personally become comfortable with the OI Handy Pro, and I would prefer using it in the posterior fossa. The flexible scope for me has very particular indications. I use it for, and we do them less and less now for multiloculated hydrocephalus and choroid plexus cauterization, where you really need to move, in the temporal lobe. You need to get around the horns. Then the flexible scope is useful. But the posterior fossa is quite a small space. There aren't many places that you can't access with a rigid scope. So my answer to that would I prefer the rigid scope, Suresh.
Perfect. Okay, can I invite the panelists, please, Dr. Venkatramana, Eddie, and Dr.
Llewellyn,
Bhartiya.
it's a very, very comprehensive and a very nice talk. Congratulations for that. And I would like to know, how do you choose the patients for the surgery? When do you choose that? Now, if they have very frank symptoms like raised ICP, absolutely there is no controversy about the surgery. Now, when they come with recurrent, frequent headaches or a very mild cerebellar signs, what is your policy? You wait and watch, or you straight away take them for surgery?
Neelam, that's probably the crux of this whole issue. And I think coming up with a standard way of recommending that is difficult. The only thing I could suggest is you individualize these. I found as soon as I become blasé about an approach, I prove myself wrong with the next case. So you've got to individualize that. I mean, I've seen patients present with huge cysts in the posterior fossa, completely well, incidentally picked up, that I've watched, and they've done pretty well. And patients present with small CPA arachnoid cysts, with profound symptoms, tinnitus, hearing loss, facial palsy, and you've got to fenestrate those, and they've done pretty well. So I think you've got to individualize patient presentation together with imaging and make your decision on an individualized basis.
If the child comes only with headache and very frequently visits your clinic with the headache, will any other modality like measuring the ICP or something will help you making the decision, or you go by the pure your clinical judgment?
No. Look, I've been a very strong advocate for monitoring ICP either invasively or non-invasively, depending on what you have at your disposal. So when you reach that treatment dilemma or dichotomy, where it's just headache, recurrent headache, and the scan's not normal, I would definitely monitor ICP before I decide. And you've got to just put that symptom complex into whether raised ICP from hydrocephalus is more prevalent in that patient than compression of the brainstem, cranial nerve dysfunction. So what do you treat is the other thing. Because a lot of these patients have ventricles that are not normal and distorted posterior fossa structures.
Right. And when you use the rigid endoscopy for the CPA angle cyst, I mean, you will go through the parenchyma of the cerebellum, or you will do any other method to extract the cerebellum?
Yeah.
Really go through the parenchyma. It's not really minimally invasive anymore.
Yeah, no, look, I've tried to not do that. So I've tried to open up the CP angle system, preserve cerebellum. Even if I need to do that with a microscope to open up first, I'll always try and do that before I go through cerebellum. So if you have to, well, then, you have to. But I agree with you. It's not really, minimally invasive, is it? But I think by and large, I've managed to open up the cysternal space where I haven't had to traverse cerebellum to get there.
Thank you.
Anything else?
Ari, you have any questions?
Yes, sir. Hi, Dr. Llewellyn. Nice to meet you. Just a few questions from your presentation, then a few points for general discussion. So for a CP angle lesion, where do you place the burr? You have an infratentorial approach or lateral suboccipital, like in continuation with Dr. Venkat's question. The case you showed had a parenchyma cover. So you prefer an approach transcerebellar. So the approach and the burr hole will be decided based on the scan, individualized. So how do you go about that?
Absolutely. This surface landmark traditionally that we use needs to be modified for each patient. I would modify it specifically to try and get as lateral as I possibly can for that particular case. And if I need to use a microscope to try and retract the cerebellum before, so expose the cyst and then get my scoping, which we've managed to do. I think positioning here is about as important as where you place the burr hole. So you've got to position the patients correctly, and if you take enough time, the cerebellum does allow you some space. Look, I accept completely, not in all cases. There have been certain cases where we've had to take a bit of cerebellum laterally. But by and large, if you position them correctly, get your burr hole laterally, you should be able to get into that CPA.
Okay. And in your presentation, you mentioned that to avoid a Y connector. So why do you think it should be avoided?
Yeah. So you would
Suppose there is an arachnoid cyst and
Yes.
hydrocephalus, if one has to put two shunts inside, so the logical thinking would be to connect both the cranial end and put a single abdominal end. So how would you like to avoid a Y connector and have a single abdominal tube?
The question with that from our perspective is if that shunt malfunctions, how do you know which catheters malfunction? And I come I come from Jonathan teaching that shunts are complicated. Don't make them more complicated. So if you can, at least you can separate them to some extent. And my experience with the Y connector has been just avoided. And I understand people who kind of use it more and maybe a bit better than we are doing it. But I just, I haven't had a sort of useful experience with them. So I try and keep shunts as simple as possible, even if it's too separate.
So in your practice, you put two shunts separately to complete different systems, one into the cyst, another into the hydrocephalus. Of course, the need may not be common, but in case if it's required.
I haven't had to do that. Let me be honest with you, touch wood. I haven't had to put two separate shunts in. And maybe that's why my leading has been to, kind of avoid that. But if you can fenestrate the compartments and get by with one shunt, obviously that's ideal. But, given that sort of decision making, I would have to say I would put in two separate shunts rather than put in a one. I haven't had to do that. Should I be faced with it, I would put in two separate shunts.
Dr. Bhartiya is there.
Yeah, hi.
Yeah, hi. Yes, you have something to say.
It's a wonderful presentation and you have covered almost everything. In continuation to the last discussion, I think what I understood was that you do cystoperitoneal shunts and if required, and ventriculoperitoneal shunt separately. And that is why probably one reason that, another reason I mean, that Y connection you don't use. Besides that, you would like to know which shunt is functioning or not functioning. Number two, you have made differential diagnosis with different other problems. How do you differentiate between hydatid cyst and the cortical cerebellar arachnoid cysts? So if you plan to put an endoscope, and if it is a hydatid cyst, then you are in trouble.
Yeah, so look, that's the question, isn't it? So I always, well, not always, but as often as I can, try and use the microscope to at least dissect and expose the cyst. Secondly, on imaging, you can, if you have a decent sort of radiologist and you look for certain described features, I think by and large, mostly you can differentiate, a hydatid from an arachnoid cyst. The wall tends to be more kind of, irregular. There tends to be a bit of calcification. The daughter cyst you can see. So there are some described ways of differentiating the two. But, again, touch wood, we've never had a case where I put a scope into a hydatid cyst. We've managed to kind of, make that diagnosis beforehand. But one just needs to be cautious. I don't have an absolute answer. You just need to have kind of, good relationship with your radiologist and go through these things in detail.
So if you open up with a small craniotomy in the beginning, and then you use the endoscope. So do you see vasculature in arachnoid cyst and which is not seen in the hydatid cyst?
Yes, yeah, I think that's a useful differentiator. I mean, the hydatid cyst is completely avascular. So yes, that is a useful differentiator. Yeah.
Good, Llewellyn. I think Dr. Devpujari has just joined. Before I invite him to discuss with you, I just want to know, when you talk about shunt, you mean ventriculoperitoneal shunt? do you?
It depends. It depends, Suresh. You know, for the posterior fossa arachnoid cyst. So that when I'm talking about the context of a VP shunt.
Oh, I'm sorry. You know, it's a ventriculoperitoneal shunt or cystoperitoneal shunt. But my question is, you know, do you think rather than peritoneum, there is any other place where you would like to put the shunt into, like cistern?
Yeah. You know, because of third ventriculostomy and fenestration, that Torkelson shunt that, you know, into the cistern has become almost redundant. I'm not so sure if you guys still use them. I have to say there would be a reason for me to exclude the peritoneum before I would look elsewhere. And that's just from personal experience. You know, I mean, I know a lot of people prefer, the Egyptians prefer putting shunts now into the sinus. So depending on where you go, you know, people will put the shunt, you know, where they prefer. For me, the peritoneum is still the first distal point of call, and then I'll work my way up. So I wouldn't really shunt into the cistern. I'd rather try and fenestrate it endoscopically.
What about putting the shunt into the ventricle? You know, cystoventricular shunt. There have been reports about this procedure as well. Posterior fossa cyst to supratentorial ventricle.
Yeah. So look, it's not something I do routinely. If I put a device or at least a stent, I would put in a stent rather than, you know, that opens, that keeps my fenestration open, and then we tend to anchor them. So no, I've never put left a kind of dangling device between the ventricle and the cyst. No. Is that something you do routinely?
Dr. Depujari, something to add?
Dr. Sankhla, just a minute.
Yeah, sure. Go ahead.
Because you said put shunt from cyst into the ventricle. What has been reported is cystoperitoneal shunt and ventriculoperitoneal shunts are sometimes required separately. Now, if you put a shunt from cyst into the ventricle, then maybe that the passage is not clear. There may be aqueductal block or some problem. And your cyst will also not be taken care, and the hydrocephalus will also not be taken care.
Yes, theoretically, yes. But, you know, there are some good successful reports on this procedure.
So let us hear Dr. Shekhar.
Well, I'm sorry, I actually came in late. I thought we were starting at 5. I'm terribly sorry about that. But I think when we are putting, shunt within another cranial cavity, the biggest problem is there a pressure differential at all? And especially if you are putting in the supratentorial compartment from infratentorial compartment, I'm not sure how will it work in a standing posture or a sitting posture. So I'm not sure of that, but vice versa can be done. If you have a suprasellar cyst, you can probably, you know, like the earlier shunts used to be put in cisterna magna, something like that you could probably be successful with, but vice versa may be very, very difficult. The other question is that in posterior fossa, fenestration can sometimes be very, very difficult to find a good place to do a fenestration. I'm sure you must have discussed that earlier, but my question to Llewellyn is what percentage of posterior fossa cyst you managed to do a successful fenestration, and what required shunts?
It's a difficult. I would be thumb sucking that a bit, but I would think more than half of them. But the point you make is, I mean, that's the difficulty here. It's such a tight space, you know, finding an adequate place to fenestrate is so difficult, which is why I made the point during the presentation. If you can fenestrate them easily with a microscope, rather do that in the posterior fossa. You know, it's very sort of sexy to use an endoscope, but if it's easier to fenestrate with a microscope, I'd rather do that.
I agree. In posterior fossa, I think microsurgery will have a significant utility, except probably in quadrigeminal cyst. I thought you were going to cover the quadrigeminal cistern cyst as part of posterior fossa cyst. Then you left it hanging in the middle bits. It's pathophysiologically, it's a posterior fossa cyst which permeates supratentorial. So I think it won't be unfair to discuss that here, because that is one condition where the endoscopy will be very useful. That and will be really minimally invasive compared to a full craniotomy. I would like your thoughts on that, like various approaches for quadrigemmal cyst, and whether you do supra or infra, or if it is infra, how will you plan the fenestration, site of fenestration?
Well,
I would like to make a comment after Llewellyn has spoken. Okay.
Okay, sure. I'll go first then this time, Chandrasekhar. No, I agree with you completely, Ari. I mean, the reason I didn't speak is exactly for what you say. They tend to herniate supratentorially, and if you're looking at a treatment approach, I would rather bunch them with the supratentorial. So I've almost, the bulk of them I would approach via the ventricle and fenestrate, and if we need to, do a third ventriculostomy. And very, very rarely, if at all, would I approach a quadrigeminal plate cyst in a cyst infratentorially. That's my approach. Let's hear what Dr. Pujari says.
No, I wanted to say the same thing. Actually, quadrigeminal cyst fenestration is much easier to do from supratentorial. Sometimes you can do it even through a lateral ventricle.
Yes.
If you do not have a very dilated foramen of Monro, I have a couple of cases I have done even through lateral ventricle, because they are bulging into one occipital horn so much that you can very easily get through there. There's hardly any brain in between. This has actually happened to me in 2 cases of fourth ventricular cyst as well, that they virtually presented in the per occipital part of the ventricle, and there was virtually nothing, and I could fenestrate 2 fourth ventricles through the occipital, and I'm sure you may have had some experience like that. So I think primary idea, when you have a large cyst which is coming up above the tent, you can actually usually do it through a supratentorial ventricular approach.
Yeah, I agree. Most of this, though the origin is infratentorial, you will see them bulging through the medial occipital brain with a thin membrane at the lateral ventricle. So you can fenestrate, and as we enter, you will see the clear cerebellar parenchyma folia or superior surface of cerebellum could be nicely seen. Only if you can't see, then you may have to enter the third ventricle and fenestrate posteriorly. Another point I want to make is the symptomatology question which Dr. Venkat asked. All these patients may not have raised ICP every time. We also have to look at the cognitive development, because many of them can have cognitive decline as the main presentation. And that also would require treatment, and waiting for raised ICP may not be the case in many cases. Your comment on that?
My comment is I completely agree with you. So 2 of the cases that that presented to us presented exactly like that, with developmental delay, and 1 child actually improved. So you're absolutely right. You don't have to wait for raised ICP. Oftentimes it's a lot more subtle.
Looking at the pathophysiological process in arachnoid cyst, you know that it is causing a compression. If you look at the Blake's pouch cyst, which will also look similar, especially a retrocerebellar arachnoid cyst versus a Blake's pouch cyst, can be difficult in differential diagnosis. So if you have a child with the Blake's pouch cyst with normal cognition development with significant hydrocephalus, what will be your plan of treatment? Observe or intervene?
Those Blake.
Here's an open question to other panelists too.
Yeah. I'm going to leave that to get some opinions before I give you mine.
No, I think if there is an intellectual deterioration, you must treat that.
No, there is a dilatation, progressive dilatation of ventricles with loss of parenchymal thickness, but the intellectual quotient is still not affected, and there's a progressive ventriculomegaly and increased head size. What would be your comment? I have an image. If the moderator agrees, I can show that, but of course we can discuss even without that.
I think let us discuss. Do you want to see the image, Venkat?
No, not necessarily. I feel if the ventricular dilatation is the primary thing, I would like to do an ETV. So I think that would be the ideal option to do that for the Blake's pouch. Suppose if there is no ventricular dilatation and the child has intellectual deterioration, I would like to do that directly to deal with the cyst. Now, interestingly, unlike supratentorial arachnoid cysts, posterior fossa arachnoid cysts have a very varied, sometimes very, very unusual clinical presentations. Some of them, decreased scholastic performance is one of the commonest things we think we need to look at. Though we always link this to supratentorial hydrocephalus, but it's quite often seen in posterior fossa arachnoid cyst. That's number one. We had certain interesting children with a bobble head. Ashish, can you mute yourself? Yeah. So, bobblehead doll syndrome is one of the prepontine cysts, as Llewellyn is talking about, a retroclavicular or prepontine cyst. They can present with the bobblehead doll syndrome. That is one of the things which we had, and treatment with the cystocystinostomy completely cure the child. Now, the other interesting thing is a very abnormal behavior. A child presented with uncontrollable laughing in the school. So much so he was punished repeatedly by the teacher, and ultimately there was a large prepontine cyst. And we were debating quite a lot whether to treat with only that is the symptom, nothing else. Yet, there are some case reports saying that abnormal behavior in the prepontine cyst, we went ahead and treated, and child became perfectly fine. So these are some of the unusual presentations, particularly the intellectual and behavioral disturbances we need to keep in mind when it comes to the posterior fossa arachnoid cyst.
And what about the only head enlargement? You wouldn't consider that as an indication?
No, with head enlargement, obviously it is due to the ventricular dilatation. So if you treat with ETV, that will take care of it.
Fair enough. Shall we
basically, the cerebral parenchyma is getting compressed without raised ICP. And in the growing period of the first 5 years, if you don't take care of the chance of development as well as, because there is always a limitation in cognitive assessment in very young children. So we may not be able to pick up all those things. So if you don't treat now, after 5 years, they may be left with permanent sequelae.
All right. Shall we take some questions from the audience?
Llewellyn said he will comment at the end about this.
I think we switch over to the audience. There are some questions from the audience.
I'll take it.
Okay.
One is from Professor Yadav. He wants to ask Llewellyn, a CP angle cyst, any indication of dry field technique, especially when there is bleeding?
If there's bleeding, the dry field technique has been, recommended, particularly by the Germans, Otel and Schroeder. I've never had to do that. I think if you need to, it's an option. If you need to, it's an option. I wouldn't recommend it off the bat as a first line thing for bleeding.
Correct. Yeah. Many of the audience people, from various places, Bangalore and all that, really saw your video, which was quite impressive, using the laser for fenestrating the third ventricular flow. And they are really very much interested to know how safe it is to use this laser so close to the basilar artery.
Just one thing quickly. So I've used the laser quite a bit now. I've used it for fenestrations, across, but I don't really use it for ETVs. The German experience, so Martin Schumann and Hans Ludwig use it routinely for ETVs. I wouldn't recommend it purely because it's not something I've done, but the literature suggests you can. So I know Manas has quite a bit of experience with the laser now. He was quite keen to use that. Maybe we can ask him for an opinion, but I certainly wouldn't be comfortable enough using it just for ETVs. That's my personal opinion.
All right, Manas, quickly. Is he connected?
No, the laser is quite safe because the range which it works is only 2 millimeter. So if you're away from the vessel,
thulium laser, I think you have to be very specific, Manas.
Yes.
It is only
so what he showed was a thulium laser.
Yeah.
In the video. So a thulium laser is safe, but other lasers are not so safe. So.
Okay, fine. Any other question, Ashish? I think I'm done 3-4 questions which I had.
Yeah, nothing very specific now. The only thing is that I would like to ask one question is that in the posterior fossa midline cyst, what would be the approach? You would like to go from the top and put in a stent, or you would like to go through the cerebellar tissue and do a fenestration? So that would be something interesting to know.
Okay, so it depends. I've seen reports, particularly from Turkey, where they prefer doing endoscopic fenestration through the parenchyma. My feeling would be if it's high up enough and close to the aqueduct and the ventricles are slightly dilated, which I would expect it to be if there's obstruction in the fourth, I would go through the ventricle and fenestrate it from the top rather than through the parenchyma.
Good.
That's great.
Okay, I think with this, it's time to move on to the next speaker. And Ashish, would you like to introduce the next speaker, please?
Yeah, it's a pleasure for me to introduce Dr. Manas Panigrahi, who is a well-known figure in the field of neurosurgery in this country and abroad. Manas is currently the senior consultant neurosurgeon at KIMS Hospital in Secunderabad. His career, of course, spans with his work in clinical practice in the National Institute, in a well-known National Institute. He has been training and teaching students. He has been into clinical research. He has supervised more than 30 postgraduates for higher qualification. And alongside, he has not been lagging behind in his publications in the field of literature in neurosciences. He has published more than 100 indexed and peer-reviewed articles. And of course, he has written chapters in textbook. And everybody knows that he is a prolific neurosurgeon and always innovative in his techniques with newer ideas. And one of the interesting things which is very important is that he would try to make innovative techniques which are simple enough and they're affordable, and they also help in reducing complications. So always there is an innovative thinking in his mind about all the procedures that he does. At the same time, he also comes from a background where he has received several awards. He has the Young Neurosurgeon Awards at Kyoto, Japan, International Pediatric Neurosurgeons Award at Salt Lake, USA. He has numerous traveling awards from the ISPN Congress in Rome and Australia. And he was also awarded by the Japanese Society of Infantile Seizures. So I won't come in the way between Dr. Manas and the rest of the audience. I would now request Dr. Manas Panigrahi, please, to take over the screen and give his address.
Good evening. Thank you, Professor Pathak, for a lengthy introduction. I'd like to thank Professor Pathak and Professor Sankhla for giving opportunity to speak in this the second international webinar. This concept is quite good and keeps us active in spite of the inertia of COVID. Good evening, Dr. Venkatraman, Dr. Hemant, and Dr. Ari, and Dr. Llewellyn. My talk was on suprasellar arachnoid cyst, but then I have included the cyst of the lateral ventricle and quadrigeminal, and I saw that a lot of discussion on the confusion between the quadrigeminal and the lateral ventricle arachnoid cyst. So I think it will help in deciding. Means it probably will be helpful for all of you. That's why I didn't comment anything. Can you see my screen?
Yes.
Yeah. So I'll not be speaking on supratentorial arachnoid cyst. Though Dr. Llewellyn has told about infratentorial, I'll just confine part of the supratentorial arachnoid cyst. The first few slides are similar, so I'll just rapidly go through. Arachnoid cysts, they are benign, non-neoplastic extra-axial cysts. They have fluid which is similar to cerebrospinal fluid, and 80% of the time they're discovered in children. They develop at the 15 weeks of gestation. So that is why most of the arachnoid cyst, as Dr. Llewellyn was telling, is detected intra utero, and if they have associated hydrocephalus, they can be treated intrauteral or the early neonatal period. So primarily, the arachnoid cysts are congenital cysts, but sometimes we can have secondary arachnoid cysts. They are either the result of meningitis, trauma, or hemorrhage, or because of previous surgery in a cyst. What we'll be discussing today is about the primary or the congenital arachnoid cyst. An arachnoid cyst is different from an arachnoidal cistern. As Dr. Llewellyn explained, that arachnoid cistern has a delicate, flimsy, translucent membrane, and they have cobweb trabeculations within it. Whereas an arachnoid cyst has a thick wall of a collagen, and it is the thick wall splits into two to enclose fluid like CSF-like fluid to form an arachnoid cyst, and they do not have any trabeculations inside. And sometimes the wall of the cyst are lined by mesenchymal cells which can secrete, and that may be one reason for increase in the size of the arachnoid cyst. The commonest site of supratentorial arachnoid cyst is the sylvian or middle fossa, and the next common is posterior fossa. And in suprasellar and quadrigemellar and lateral ventricle, you have almost 10% frequency in each. I'll be talking about suprasellar and the lateral ventricle. Now, what's the natural history of arachnoid cyst? If you know the natural history, we know that all of them do not need treatment, as a few of them only enlarge, and the cyst enlarges, and even if the cyst enlarges, some of them become symptomatic, as Dr. Ari was explaining, that the cyst, there's radiological cyst enlargement, but clinically there is no change. So symptomatic only, even if there's 10% enlargement of the cyst over a period of time, only 1/4 of them will become symptomatic. That is why we have a lot of confusion and a lot of difference of opinion when patients go from center to center about the decision of surgery. Now, the enlargement of cysts has been, the natural history has been given as different by different authors. Like Dr. Al-Holu has told that the chance of cyst enlargement is 10%, whereas the other paper, they have told it is 0.7% only. But then what has to be remembered, that the chances of symptomatic at follow-up is almost 1 to 3%, and the chances of cyst enlargement is almost ranges from 1 to 10%. Now, what are the predictors of surgery, or which are the cysts when you see a first scan that they are likely to increase or they need treatment? So if a person comes with the age of less than 4 years, they have a higher chance of, or less than 2 years, they have a higher chance of progressive increase in size. Adults usually don't increase in size, so we do not have to keep on repeatedly doing an MRI to document increase in size and treatment. Whereas children, one has to be careful. The other is location of cyst. If it's a suprasellar or intraventricular or in the quadrigeminal, these three areas have a higher tendency to increase in size, or any minor change in size, they can cause hydrocephalus. So they become symptomatic. So if these two factors are there, then one has to follow them clinically, even if they are detected incidentally. I'll give an example of a case which I had operated a few months ago. Here, this is a suprasellar arachnoid cyst with ventriculomegaly. And one can see here that the basilar artery is in the center of the cyst. It is not draping on the brain. Now, I'll explain the significance of it in my later slides. So we did a standard frontal burr hole. We identified the foramen of Monroe, and then identify the floor of the third ventricle, and then did a cystoventriculostomy. That is the first step. But then, is it enough, cystoventriculostomy? The cystoventriculostomy, now this can be done on that day. The laser didn't work, so I had to use a Fogarty. But laser is whenever there's a thick membrane, laser is very comfortable because it doesn't cause any, you don't have to manipulate the floor of the third ventricle. Once the cyst, once you have done the communication of the cystoventriculostomy, the second step is to inspect the cyst and do a cystocernostomy. So after the cystoventriculostomy is done, you enter the cyst, and here you can see the ventricle floor of the tab, and the vessels are seen. There is another second membrane where one has to make the cystocernostomy. So this is the picture of the video of the cystocernostomy. One can see here that the basilar top of basilar is in the center of the cyst, and there's a thin membrane draping on it, which has to be punctured. So cystocernostomy. So this is completion of the procedure, ventriculocystocernostomy. Now, what is enough? Is it ventriculocystocernostomy ventricular cystostomy is enough, or one has to do a ventricular cystocystonostomy. Now, this paper came in 2011, where they compared the number of, they did analyze all the cases. They took out some of the 44 cases which were reported, where they had done only ventricular cystostomy, but the number of patients who required reoperation were 16%. Whereas patients who had ventricular cystocystonostomy, there were 86 patients which were studied, and the reoperation rate was 8%. So this itself tells that it is always better to do a ventricular cystocystonostomy rather than stop at ventricular cystostomy. Now, do we need to treat all suprasellar arachnoid cysts which come to the OPD? How do we decide that which one needs treatment? As Dr. Llewellyn was telling, majority of them are detected in the in vitro period, and some of them decrease in size and disappear, or majority of them decrease or disappear. But then surgery is required whenever there is an increase in size of the cyst, or when they present with a raised ICP, or they have visual disturbance. But if the patient comes with only endocrine disturbance, that's not an indication for surgery, because even if you operate patients coming with endocrine disturbance with a suprasellar arachnoid cyst, post-operatively, they have not shown any better outcome. So surgery is done only if there is a raised ICP, visual disturbance, or if you document that the size of the cyst increases over a period of time. Now, why do the cysts increase in size? They increase because there may be a fluid secretion by the cyst wall. They are all theories, they are not confirmed. Or there can be a one-way valve mechanism around the basilar artery, as with CSA pulsation there is entry into the cavity, or there can be diffusion gradient between the fluid of the cavity of the cyst as well as the CSF. Now, this diffusion also can increase in size. Now, but how do we predict that which is a arachnoid cyst which is likely to increase in size, to decide that this patient needs treatment or needs a close follow-up? Because we know that the cyst size increases probably by a ball valve mechanism, and if you can demonstrate that it's communicating type, then we can suggest surgery in early phase. Now, earlier people used to did cystonogram, and then there was immediate filling of the arachnoid cyst that was classified as communicating. In some patients there was delayed filling, and some patients it never filled. So they classified the arachnoid cyst into 3 types, and this communicating type have this communicating and immediate filling and delayed filling, because of the continuous pulsation, they have a chances to increase in size. But a non-communicating type, if the absence of raised ICP, probably they will not increase in size. So if you have this kind of, if you know what is a communicating or non-communicating, probably you can make a decision that to treat or not, early or not. Now, people have done studies with intrathecal metrizamide scan to decide whether it's a communicating and non-communicating, and to decide the management. And many times they have avoided surgery also. But the previous 2 paper I quoted was an invasive way of documenting, which is a communicating and non-communicating. And this paper came in 2015 of predicting the way to, in non-invasive way, with an MRI with cystonogram, how to with MR cystonogram, how to predict a communicating and non-communicating. Now, as all of us know, that the Liliequist membrane has 2 leaves. One is a diencephalic leaf, one is a mesencephalic leaf. Now, the diencephalic leaf can split into a cyst and form an arachnoid cyst, or you can have a cyst formation or fluid collection between the diencephalic membrane and the mesencephalic membrane. So there are basically 2 types of cyst. One is a splitting of the diencephalic membrane, that is type 1, or a second type is between the diencephalic membrane and the mesencephalic membrane. Or so the second type always communicates with the subarachnoid space. There's a type 1 which is just splitting of the diencephalic, does not communicate with the diencephalic with the subarachnoid space. So in the type 1, because it's a splitting of the arachnoid cyst, it pushes the vertebral artery behind. So the basilar artery behind, so the basilar artery will be draping on the midbrain. Whereas in type 2, where it's a dilatation, it's an expansion between the diencephalic and mesencephalic, the tip of basilar artery will be freely lying inside the cyst. So the video which I showed, that was a type 2, and so we had to do a third ventriculostomy with, and again, cystoventriculostomy and a cystonostomy. So in that paper, they described that in addition to type 1 and type 2, there is a third type of subarachnoid suprasellar arachnoid cyst. That is, if the cyst enlarges or extends laterally into the medial canal fossa. But so what is the surgical strategy if we know? If it's a type 1, then because there is a communication, there is need, and if the patient has hydrocephalus type 1, it will not increase in size. But if it's asymptomatic, you can follow up, do not do anything. But if it's symptomatic, one has to treat. So if it's asymptomatic, one need not treat, and many of the time they'll remain like that for the lifetime. But type 2 and type 3 who are communicating with CSF, if they are asymptomatic, they should be observed because the size can increase or decrease depending on the movement of the CSF fluid. Whereas if they become symptomatic, they should be treated. So this is what the example had shown. This is a type 2 cyst. Patient came with hydrocephalus, so we had done surgery. Now this is the type 1. This is a type 1 case. This can see here. This is the MRI. This is a suprasellar arachnoid cyst. We had done an MRI angio and then integrated. You can see here that the artery is draping on the midbrain. So, but again, this patient had come with symptomatic symptoms, so we had to do a surgery. But it's a splitting of the diencephalic membrane. You can see here is a very thick membrane, difficult to puncture. So one has to, after puncturing the cyst, one has to dissect all around so that the aqueduct should be free. Many times it's adherent. One has to free the aqueduct. Just checking that the aqueduct, there is no aqueductal stenosis. And after that, one has to enter the cyst and do a cystonostomy as I had shown in the previous video. So what do you do if the treatment options, if endoscope is not available? It's all historical, but then in our country, there are many centers where sometimes endoscope doesn't work or endoscope is not available. What can be done? Now one can do a craniotomy and cyst excision through a TVNL approach, or one can do a shunt of the cyst and the ventricle, or people used to do earlier percutaneous ventricular cystostomy. But if one looks at this paper, they compared all the 4 methods. The best result for this endoscopy, the improvement of the 90%, whereas in craniotomy excision was 80% and worsening rate was 20%. In only shunt, it is 85%. Percutaneous ventricular cystostomy is 80%. So if you have endoscope, the endoscope is the best treatment for suprasellar arachnoid cyst. Having told, let me tell about something about the arachnoid cyst of the lateral ventricle. This was a 12-year-old female who came with blurring of vision for 1 month, and these are the images. Yes, she had a large cyst in the lateral ventricle. The opposite ventricle had almost, the septum pellucidum was pushed, and the opposite ventricle was small. So what we planned was to do a septostomy to communicate, because we are not sure whether we can communicate with the foramen of Monro. So we planned for a septostomy and then cystoventriculostomy on the ipsilateral side. So the first step after entering the cyst, we did a septostomy. This is what we are using a laser. And make multiple perforations and then finally enlarge the perforation with a Fogarty catheter to complete the septostomy. And at the end, you go across the ventricle to explore the opposite ventricle. The next step is communicating the cyst to the ipsilateral ventricle. And the best way to do is identify choroid plexus and coagulate and make an incision along the choroid plexus. So that's the confirmation that the cyst is communicated with the ipsilateral ventricle. So we had communicated the cyst to the ipsilateral ventricle and communicated to the opposite ventricle, so that through the foramen of Monro of the opposite side it can drain. Now this was another patient who came with headache of 6 months. Then he had a cyst in the atrium and the lateral ventricle. Now one can see here that this is communicating with the vellum interposition system, as you can see here both the internal cerebral veins. Now here again we did a cystoventriculostomy with the ipsilateral ventricle, and then identify the choroid plexus through the cyst to communicate to the interpositum system. And once that is done, the cyst, again, as I was explaining, is peeled from the wall slowly if it comes out, but if it bleeds, one should not do. And so that it collapses into a small cyst, so that the chances of recurrence of cyst is less. This is the peeling of from the walls of the ventricle. And at the end, we look for here again the same principle, identify the choroid plexus and incise the arachnoid along the choroid plexus, so that probably you can communicate with the interpositum system. This is what communicating with the interpositum system. And this is the post-op scan. The cyst has collapsed and patient is clinically better. Now you have similar patients like this patient who had the confusion to do it through a supratentorial or infratentorial. Is it a cistern of the quadrigeminal cistern, or is it lateral ventricle arachnoid cyst arising from the interpositum cistern? Again, this another case extending into the quadrigeminal cistern here, whether one has to do to the supracerebellar infratentorial way endoscopic assisted, or do through the ventricle. As Dr. Depujari was telling, is it easier to do through the ventricle because it bulges into the lateral ventricle here, one can see here. Or this case. Now this case again is a quadrigeminal cistern who came with behavioral disturbance and a memory impairment. But one striking thing was that the vein of Gallen, the deep venous system, is shifted superiorly here. So by definition, this is the only cistern which is quadrigeminal cistern. But in the previous cases, the veins are let me show you the relevant. The veins are pushed inferiorly. So these are not quadrigeminal, by definition, not quadrigeminal cistern. They are extension of the posterior interpositum cistern. So whenever there is the diagnosis is an interpositum cistern or the vein is displaced inferiorly, it is better to do through the lateral ventricle. But in a case like this, where the vein is pushed superiorly, probably doing through the infratentorial supracerebellar and endoscopic assisted is a better approach. As when you do through the lateral ventricle or through the third ventricle, we might encounter veins, and because this was the mistake we had done, I had to do a cystoventriculostomy through a very narrow space, and I was very afraid to do that. So this interventricular arachnoid cyst in the body of lateral ventricle has been classified, as I explained you, because most of them origin from the interpositum cistern, and it can extend into the lateral ventricle or superiorly into the septum pellucidum cistern. And so it is easier to operate through the lateral ventricle. So, and in that paper, they have classified that it's depending on the vein, if the internal cerebral vein and the vein of Galen is identified, if the cyst is above that, it's a velum interpositum cistern, and if it's below that, it's a quadrigeminal cistern. So probably it is better to go posteriorly. But if it's a velum interpositum cistern or in the lateral ventricle, then it's better to go to the lateral ventricle. In conclusion, arachnoid cysts are benign lesions. Only symptomatic cyst needs to be treated. Only 10% of the arachnoid cyst needs surgery. Proper interpretation of MRI is essential to classify and plan treatment. Thank you for your attention. Hello.
Thank
Ashish?
Manas is a very nice presentation, especially very good images to describe the understanding of the pathophysiology, MRIs. In the, this type 2 variety of suprasellar cyst you described,
Yes.
you don't need to communicate with the cistern, just the ventricular cisternostomy is sufficient.
No, sir. Means in all the types you need to communicate. It is only a question, but in a type 1, the second membrane will be very thick because it's a splitting, whereas in type 2, because it's the mesencephalic membrane, it is thin. It's easier to do.
Okay. So it's only a technical point, but otherwise.
No. But type 2 means type 2. They have it either they can spontaneously involute or they can increase in size because it is in communication with the CSF space. Whereas type 1, they will remain static. And but if they become symptomatic, they have to be treated off.
So what do you do when the cyst recurs after some years?
Manas?
Hello.
Disconnected?
Yeah, I think he went offline. Looks like.
Anyway, Dr. Bhartiya, you have any thoughts about this?
About the same thing what Venkatraman.
Yeah, Venkat's question.
That both, in both the cases, type 1 and type 2 of the cyst, whether it is communicating or non-communicating, the better is to do a VCC, ventricular cisternostomy, because otherwise what may happen that because of the large suprasellar cyst, the third ventricular wall is stretched, and once decompression is done, in most of the cases this wall will obliterate this cystoventriculostomy. So if you have a cystocysternostomy also, then it will continue to drain. Another point is the association of the aqueductal stenosis because of the long standing pressure. There may be inflammation and the aqueductal stenosis. So then in that case also, if you have done a cisternostomy, the CSF will continue to egress and the pathway may not be blocked. So these two advantages are there of doing a ventricular cisternostomy. Another point is with Dr. Manas' presentation, and as we know that either they may be symptomatic or asymptomatic. The asymptomatic patients may present with even with the endocrinopathy and also with gaze palsy. These two do not make an indication of surgery. So if it is asymptomatic with gaze palsy or endocrinopathy, you still can continue to observe the patient because these things do not usually improve following the surgery. And in rest of the patients who are symptomatic with other symptoms of raised intracranial pressure, motor deficit, or other symptoms of visual acuity diminution, etc., then you need to operate.
Harry, your views on this?
Yes. A nice presentation, Dr. Manas, and can hear me? Yeah. So, like continuing comments by Dr. Bhartiya, the classification of suprasellar arachnoid cyst is to understand when to intervene and which type of arachnoid cyst can proceed to cause symptoms. That was the whole idea of the paper by Andrea et al. Is suprasellar SAC type 1 is the bulging of the diencephalic membrane of the Lilliquist membrane, whereas in SAC2, the diencephalic membrane is intact, so thereby it prevents pressure on the third ventricle, whereas the fluid is ingress into the cyst through the mesencephalic membrane defect. So they present more with hydrocephalus. My question to Dr. Manas is based on this. What would be your approach for a suprasellar arachnoid cyst without hydrocephalus, with symptoms? Or rather, what symptoms in a patient with SAC would you like to treat when hydrocephalus is not present?
Yeah, there is visual disturbance. Patient who has come with visual disturbance, but then you cannot do endoscopy. Then doing a TRNL endoscopic assisted surgery and fenestration marsupialization is good. So that is the only indication in absence of hydrocephalus. But otherwise, as Dr. Bhartiya was telling, and I also quoted that endocrinopathy is not an indication of surgery in suprasellar arachnoid cyst.
Yeah, and I think
isolated gaze palsy, like if sixth nerve palsy is there, and
Yes.
it is because of the cyst pressure, then you need not to operate. But if it is because of the hydrocephalus, then you have to operate.
Correct.
difficult to
So
differentiate.
that sixth nerve is a little controversial because
Yes.
when it comes to sixth nerve, it has gone beyond the suprasellar space.
Yes.
So then there is a chances that they are ones which are progressive in size. So that comes as type 3.
I think
So
I would
that
agree
is a
with
controversy is
Yes.
there. That whether you means many people suggest surgery is better in that.
I think there
Manas,
is
what are the options for the recurrence of this cyst? Again, you do the just redo endoscopic procedure, or you put any devices like stent, or you think of a shunt.
Yeah, if there is a recurrence, redo endoscopy is the first option. But if the ostium is open, then shunt is the better option. Shunt is the better option to place a shunt. But if
there's
the
not much
ostium is closed,
Your first option, you will try endoscopy and then wait. If it doesn't work, then you go for shunt.
we'll do a CSF flow study.
Yeah.
And if there is a patency, then straight away go for a shunt.
Okay.
I think there's not much debate regarding the cystostenostomy or only cystostomy, but
Yes.
a lot of cystostenostomy is definitely superior and has got better results. Your comments on actually the challenges in perforating the cyst, because that is a very practical problem when you go in and see, because the cyst will be large, flapping, sometimes maybe you will have difficulty to coagulate, and also to enter and do the second part. Like in one of your cases which you showed, all the leaflets were they're all crumbling and
Collapsed. Yeah.
collapsed together, and to reach the ETV site may be a challenging task.
Yeah. See, that's a case which I had done long ago when we did not have laser. In absence of laser, to make an opening as a term means the cyst wall keeps on. You cannot perforate with your Fogarty. You have to use scissor, and it keeps on moving. So those are the cases where laser is very helpful, so that you can make a very wide opening. And if you make a very wide opening, then it is easier to enter into the cyst and do a cystostenostomy.
Would you constrict the cyst by coagulation, progressive coagulation?
No, because I try to avoid doing coagulation because that might cause later again adhesion. so I do not do coagulation. I just separate from the ventricle as I showed, and so that it collapses, but no coagulation to shrink it.
In both the talks, we have not discussed the problem of subdural collection versus hematoma. So I would like to know the experience of both the experts, because these are known complications and they're about 10 to 15%, so they cannot be ignored. So what is the experience of both the speakers actually in terms of these two complications? They're usually treated conservatively and it subsides, but what's the experience?
Subdural is one of the reasons of developing subdural is if one does not feel the ventricle at the end of surgery. So at the end to prevent that, still it happens, but to avoid that, one can fill the ventricle and plug the cortex, the whole of the cortex. Then the chances of one can avoid the chance of developing subdural collection. But in spite of that, we have faced that, and we have done re-exploration for subdural, and there is a recollection of subdural become subdural hygroma. Then we have put a shunt. When I put a shunt, the hydrocephalus had increased. So for one patient, we had to do procedure for 4 or 5 times. And at the end, we had to do a shunt for the subdural space and ventriculoperitoneal space, and then he settled. So, and at least at that time, I did a literature review to find out what is the cause and how to avoid. I did not find anything much, but plugging the cortex has reduced the incidence in my experience.
Is Llewellyn there with us?
Yeah, I am. So we thankfully have had a huge incidence of subdural collections, but every endoscopic procedure always fill up with wash after, and we use a Biko sort of mushroom spongy stand that we use to fill the tract. So every procedure gets that. But if you have a subdural collection that's symptomatic, they can be difficult to treat. So I would make every effort to make sure that you fill the cavity with wash and plug before you flush.
The other thing I would like to ask is for the cortical cysts or the Sylvian cysts, you would prefer a dry field or a wet field, because there are added advantage of both, plus and minus points for both. So what about the two aspects of it?
For the Sylvian fissure cyst, no, we have done wet field, but but we have many times we have done a craniotomy at the junction of the cyst with the normal cortex also, so that to the basal cistern you use endoscope with a dry field to make that opening, but we communicate with the convexity cisterns also to have advantage of, it's not only communicating with the subarachnoid basal cistern, but communicating with the convexity cistern also is important. So dry field is very helpful in that case. Earlier used to do wet field, but I had problems, recurrences. But doing this combination of communicating to both basal cisterns and convexity cistern has helped.
Can I ask? There is a lot of actually challenge in diagnosing a recurrence in this cyst than the primary diagnosis. In continuation of what Dr. Venkat asked, it's easy to decide in the beginning. There's a large cyst with hydrocephalus. You go in and do endoscopic cystostomy and cystonostomy. But post-op, the image will look the same or almost same with small, probably mild reduction of the cyst. And these ventricles do not collapse when only a ETV is done as opposed to shunt. So how do you follow up these children, and how do you decide that this procedure is working or not working?
Yeah, means
these are difficult decisions to make.
Yeah, suprasellar means we do regular, we do an MRI every 3 months, after 3 months and every yearly. And we have demonstrated the cyst collapse. That is why it is important in a lateral ventricle to peel off from the wall. If it's not peeled off, then it doesn't collapse. Then you have radiologically difficult, post-operatively, you have difficult to assess whether it has worked or not. And then you have to totally depend on the symptom for what you have operated. You operate for raised ICP, whether raised ICP is there or not. You cannot have a radiological follow-up. But after we started peeling off the arachnoid cyst, even radiologically, we have demonstrated that both in suprasellar and the lateral ventricle, the cyst size reduces. And whenever at follow-up the cyst size increases, you can always take it as a recurrence.
Can I?
Yes.
In the suprasellar cyst, besides symptomatic improvement, the radiological improvement in terms of displacement of the infundibulum or the optic tract and posteriorly the mammillary bodies, and because ballooning of the floor of the third ventricle, they regress. It is not the size of the ventricles. The size of ventricle does not regress. But these things which were displaced, they definitely regress. And they are they show that your cystocystonostomy is working. So that's what is the follow-up.
I agree with you, Dr. Hemant, but it takes time. It doesn't happen immediately, and maybe about 6 months' time, about 50% of aggression, I think, Ari, we can take it as probably is successful. And, there is no real measure to say that exactly. It's a very difficult decision, actually.
In addition to, the clinical improvement.
Yeah, in addition to the clinical improvement. And I think they all need to, that's the reason I asked. 10 years later, I had the kid was doing very well, came back with recurrence of symptoms. And the second time, the displacement is not much, but I think the ostium was closed. So we need to redo that. So there was a regression, definitely. Child had endocrinopathy, which need to be treated, and later on became symptomatic once again after 10 years. So these are something that require a long-term follow-up.
Yeah, comment on coagulation. I think I invite comment on coagulating the wall versus peeling.
Coagulating wall?
Like you said, you avoid coagulation and peel
Yes.
the wall. So I would like to hear from other panelists.
I do coagulate the upper ones, like for example, the superior wall of the cyst. You can comfortably coagulate because you have the access very well. I think the only risk I feel is that if there are any underneath some veins which we do not see. So when you go down further to do the cystocystonostomy, I think there we need to be a little careful. I use only the balloon dilatation. There I would not risk to coagulate because inadvertently you might cause the problem. But I'm not sure. I mean, Manas might have experience, but I'm not sure whether will it increase definitely the fibrosis and closure. I'm not sure. So I've used the.
What I meant was in the ventricles, sir.
In the ventricles, not in the floor. Floor, nobody has.
Yeah, right.
So in the third ventricle, I have also tried to release the membrane. As Venkat said, the superficial part can be easily coagulated and cut, and the opening can be made wider. But as you go below and in the depth, it is sometimes on its own. It is so relaxed that it falls into the field, and then it is possible to do this thing. But I have never found it, to do it all around and completely. It's pretty difficult and at times risky. I don't know how Venkat, how Manas does it.
Even technically, he has got a laser, so that is possible. Even technically, as Manas showed in the video, the angle of working will change. The ventricular cystonostomy, the angle is different. But the cystocystonostomy, the angle is going to be different. So that is another technical problem for coagulation. But if you have the single fiber laser like that, and I'm sure it's flexible and you can take it wherever you want.
Simpler, yes. Simpler. Correct. Yeah.
There's a question from Mahesh Bhatt, Kanpur. He's asking whether there is any role of Ommaya reservoir or a CSF reservoir in cystonostomies. I believe he's talking about cystocystonostomies. So he's probably asking, I would guess that he's asking whether one would like to leave an Ommaya reservoir as a sort of another standby sort of support. In the
I would recommend not to use that because sometimes they interfere with the ostium and the primary goal of treatment itself. Secondly, the incidence of subdurals can be more when you use such Omaya reservoirs after that. So there can be higher incidence of subdural collections. So it has been reported. So I think it's preferable not to use such devices. And if there is a failure, anyway, you need to deal with it in a different way totally.
No, reservoir you only use if there is some intra bleeding, and then you use a reservoir and then use the reservoir as an external ventricular drain. Like the Imai reservoir is placed, and then later we put a scalp vein from the skin and use this as a drain. So whenever we have a intra bleeding, we use a Omai reservoir. Otherwise, routinely we do not place Omai reservoir. And the other point I want to tell about this plugging the cortex is we don't use gel foam or sponge stand. We take a small flap of the pericranium. This was published by Dr. Mohanty. While doing the burr hole, we harvest a small flap of pericranium, pedicle pericranium, and take it inside and plug the cortex. And that has helped to reduce the incidence of CSF leak and subdural hematomas also.
I don't know whether, sometimes the cortex can go down because the ventricle has drained, the ventricular size has come down, it will go up and down. In that situation,
Ari also is part of that paper, I think.
No.
Ari, I would like to listen from you.
No, sorry, I am not. I need to check.
There are some more questions.
Yeah.
I don't think there are any more questions.
There are, I can see.
Yeah.
How to plug the cortex there?
Can I ask? You showed 2 patients of trigonal arachnoid cyst for intervention.
Yes.
So, what would be your indication to to do surgery in those patients? Quadrigeminal is different. Here, trigonal, when the arachnoid cyst is present only in the trigone.
Yeah, the size
When
of the.
would you consider surgery?
Yeah, both the patient which I showed, they came, means one was the huge one in the lateral ventricle, it was a 12-year-old child. The other trigone was an adult patient who came with persistent headache. And we see that the size of the trigone from the contralateral side, it was almost 3 times more. And the patient, we first gave a trial of medical management of giving painkillers and all those. He continued to have headache. And so our indication is persistent headache in spite of medical management.
Yeah, I've seen a few patients where the cyst dilatation itself can cause raised ICP.
Yes.
And a second indication would be when the trigonal arachnosis is causing obstruction at the atrial level and a temporal horn loculation, which again will be an indication for definite surgery because the egress or the circulation of the CSF is blocked.
Yeah. So that again will cause headache only. I mean, they present with headache. There is one question, a lateral ventricle from where to place the burr hole in lateral ventricular arachnoid cyst and role of image guidance.
Yes.
Yeah, role of image guidance means it's very helpful image guidance. But when you use image guidance, once you puncture the ventricle, the accuracy changes. So as Dr. Llewellyn was telling, if you have an endoscope, navigated endoscope will be very helpful when used for endoscopic procedures. The planning the burr hole depends on where you want to do the fenestration. If you're making a lateral ventricular arachnoid cyst, because as I showed the case that we planned for septostomy as well as communicating with the arachnoid cyst, so we planned it in the parieto-occipital area behind. So it depends on what is the procedure you're planning, and your burr hole should be contralateral to that, so that your endoscope, when you place an endoscope, you can directly see your area of interest.
I would suggest again individualization of the burr hole. My idea would be if there is a dilated ventricle,
yes,
then it is better to enter a normal ventricle and then look at the cyst, because it is always easier to puncture a convex surface than a concave surface. And it is also always easier to enter a normal anatomical cavity and then identify an abnormality than entering into a cyst. Because once you enter a cyst which has only walls and there are no anatomy to guide you, it will be difficult to identify where you're going to puncture. But in cases like one which Dr. Manas showed, where the ventricles are collapsed, you have no other option but to enter the cyst primarily and then look at the thin wall of the cyst, through which you should be able to see the ventricle, and then you can puncture. Otherwise, it's always preferable to enter an anatomical cavity and identify the convex bulge of the cyst, which can be punctured.
Yeah. Means it is the problem happens where exactly means you totally depend on the anatomy of looking at the septum. So that is the place where and looking at the area where there are no veins. But endoscopy usually helps if sometimes you can land up in making a septum going through the corpus callosum if your site of puncture is not proper. So one should avoid letting out CSF while making the puncture, and keep the ventricle dilated with continuous irrigation, so that the ventricle size is same as what is in the MRI. Then it helps us, then the navigation will be helpful. Or you have to make another burrow and use ultrasound and do ultrasound guided navigation.
Manas, how do you differentiate these trigonal cysts from the choroid plexus cysts?
From the MRI only. If the cyst is coming, means the margin of the cyst is near the internal cerebral vein, then it is taken as an interposition cyst, which is lateral ventricular. But if there is no, the margin is not coming near the internal cerebral vein, that has to be choroid plexus cyst.
I think that was a fantastic session, and I thank both the speakers for excellent talks. This would bring us to the end of the day. I thank the panelists for active participation and giving their valuable comments. It was a very interactive session. Before I close, I would like to announce that the next talk is on 11th of October, which is another Sunday. And it would be on endoscopic management of ICH. And the second talk would be on endoscopic excision of parenchymal lesions, do's and don'ts. With this, I thank the president of the society to conduct this session, and I hand over the screen to Mr. Naik.
Yeah, thank you very much, audience, for joining us today. We had 316 logins today to have this webinar, and our logins have come from 5 countries and 19 logins have come from abroad. So congratulations to Neuroendoscopic Society of India, its president Dr. Suresh Sankhla, Professor Ashish Pathak for organizing such a wonderful webinar with luminaries of neurosurgery from across the world. We thank Professor Llewellyn, Dr. Manas Panigrahi for their wonderful sessions, and duly assisted by our panelists Dr. K Venkatraman, Dr. Arivazhagan and Dr. Hemant Bhartiya. We also have special thanks to Dr. Devpujari sir, who came in to give his expert guidance. So we thank Neuroendoscopic Society of India for giving us this opportunity to carry this webinar. We really enjoyed it. We thank the audience to come in large numbers. And as sir has said, we wait for the 3rd episode of this webinar series. This is Deepak Naik on behalf of Health and You signing off. Thank you very much for joining. Please continue to support Health and You products. Have a good night.
Thank you, Mr. Naik. Thank you.
Thank you, sir.